Our next speaker is Professor Jan Davies. Jan is a professor of anesthesia and adjunct professor of psychology at the University of Calgary. I've known Jan for a long time at patient safety conferences and even aviation psychology conferences over the last few years. And Jan's going to tell us about a multidisciplinary project that she's been involved in Alberta to manage the pandemic response. Thanks very much, Jan.
Thank you, Stu. So I'm going to talk today about a research grant in which I was involved, and this work has some similarities to the fantastic work that Sue just described. And I also want to echo her thanks about being invited to this wonderful seminar. It's just a great idea of Stu, so thanks very much for inviting me. I'm speaking to you from Alberta, Canada, and in this province, which is sparsely populated over a very large area, we are run by one health service, Alberta Health Services, which delivers healthcare to about just over 4 million people. But it means that all the policies and procedures come from above. And so I'm going to talk to you about the research project in which I became involved. Back in the 10th of February, the Canadian government announced that there was going to be money available for research, and interestingly, the applications were to close 8 days later, but a group of us came together and applied, and 10 days later found out that we'd been awarded the maximum funding for 2 years. And that was to look at the flow and implementation of this provincial policy in Alberta's response to the COVID-19 epidemic. And it was just at the right time because, less than a week later, we had our first COVID positive patient in Alberta, and we had full ethics approval just under another week later again. So the timing was really good. Now, as Stelmach has said, a disease outbreak is no place to begin disciplinary differences, and it might also not be the place to start a research relationship, because not all of us knew each other when we actually sat down to write this grant remotely. I was one of 2 human factors people, and I knew the other individual. I also knew the infection prevention and control specialist. I didn't know any of the organizational sociologists, but we came together writing the grant, as I said, remotely, and somehow the relationship gelled and worked really well. And so just to tell you the research approach, we had this group of organizational sociologists, ethnographers, who were really the analysts of the policy generation, interpretation, and implementation. And then the human factor specialists who like to look at human actions and behaviors through the system lens. And then the infectious disease specialists who have much more of a focus on the individual and are trying to ensure conformity to the IPC protocols and procedures. I have to confess, my knowledge of ethnography when I started on this before the study was really, really small. And since then I've learned a great deal, but my appreciation has increased much, much more than that. It's been an amazing experience. And I want to tell you about 2 concepts from ethnography that I've learned about and really come to appreciate. One is situated interventions. And that means that the experts are actually embedded in the health system or the system in which they're exploring and directly contributing to the responses. And also the idea of being an alongsider, not coming from outside with a clipboard and a checklist, and not being someone from inside who's joined the team, but coming in and being alongside the individuals. And because we lack authority and hierarchy, we've become trusted and we've become privy to basically everything that's gone on in the areas in which we've worked. Of course, we're reliant on pre-existing relationships and the goodwill and buy-in from the participants, but it's been an amazing way to look at the research. So I want to tell you about two projects of the several on which we've been working. And one was in primary care. And you think, why is an anesthesiologist in primary care? But, you know, I was part of the team. And in that project, we tried to facilitate preparedness for the clinicians and the staff as they either established new community-based clinics to deal with COVID-19 or retrofitting their existing primary care clinics. And we did that through tabletop simulations and interviews, all done remotely. And we were looking at, again, how these high-level Alberta Health Services policies and priorities were being interpreted and enacted. And I think I brought my two different points of view to this. First of all, as a doctor, because I was often asked the clinical interpretation of the applicable policies. And then secondly, as a retired anesthesiologist and obviously being interested in the N95 masks. And in our province, wearing these masks is restricted to those working with aerosol generating medical procedures. And in a primary care clinic, the only procedure of that kind would be to perform cardiopulmonary resuscitation. So that would be a very rare event. And it's not as though you can just go off and buy a couple of N95 masks. They need to be fit tested properly before use, and you always need to wear the same kind of mask again. And I think Sue alluded to that problem when she was just speaking. And one of the things I've learned is that, of course, copious facial hair will interfere with the seal of that mask, and wearers have to be clean shaven, although they can have a modest amount of facial hair, but nothing as luxuriant as this gentleman's mustachio. The other big project was on the COVID-19 patient care units or wards in the entire city of Calgary, in all the adult hospitals. We didn't actually go to the children's hospital. And we carried out ethnographic and human factors walkthroughs, sometimes with some of our IPC clinician colleagues. And we were able to make some improvements, and in three big areas, I think, in decluttering and reorganizing the PPE, in reconfiguring what we called the designated dirty tray tables and supplies. And these were tray tables that you would normally see in a patient's room, on which a patient might have a lunch tray or a book or a glass of water. And then the redesign of the handling pathways for the dirty linens and the laundry. And what we wanted to do was really identify potential efficiencies to transfer knowledge than to have each of the wards reinvent how to do things, although they were certainly free to do so. And here I drew on my background from a couple of studies in which I've been involved. One has been a multiple version of the drug drawer standardization project, which started in my department of anesthesia in my hospital, but then has gone province-wide. And the other one was on our Ebola preparation project, which we carried out, I think about almost a decade ago, and in which multiple in situ simulations were carried out. And this is the image from one of them, taken in a tent outside a simulated patient's home. And if you look at the background, under the gap, the white light is actually snow because the simulations were run in the winter. So these all had, I think, given me great preparation for what I've been doing now. I'm now going to show you just a few pictures of the sorts of things we found and we tried to fix. And the first of all is a before picture, and just to show you the color coding, the green lines show what was a clean cart with PPE supplies. But you can see here that there is a mask discarded, and I've circled it in yellow. And here's a lunch tray, and it was clean, but it's been put on a rubbish bin, which means that it's now contaminated. And here's another before picture, the bundles of PPE snuggled into a chair, another clean tray table with a lunch tray on it, with a clean stethoscope bag hanging from it, but what looks like a discarded mask and a basket of a plastic bottle of cavi wipes, which we use to wipe down dirty equipment, and then the pink bucket on the floor, which is designated for the face shields and separated from the rubbish bins. So, you know, confusion, clutter, and a bit of disorganization. But this ward in particular was given less than 24 hours to be converted from a normal orthopedic surgical care unit to a medical unit to treat COVID-19 patients. And it actually turned out that they managed the conversion within less than 6 hours. Now, here's an after photo between the clean cart and the dirty side, which is what we require. Everything is organized as much as it can be given the space available on these carts. And then here, the clinician would leave the room and would, first of all, don the gloves into this rubbish bin here, perform hand hygiene at the sink, and then move to stand here, would be able to look at the instructions for doffing while the gown was removed and put carefully into the bin, and then to perform hand hygiene again, and to come out and to put the goggles or face shield into the pink bin, and then to remove the mask, putting it in the black bin, and then to come back here, perform hand hygiene again, and re-don a clean mask. So this, I think, has been one of our successful changes. Here's where we have been continuing to do some work. This is a designated dirty tray table, and we have the bin for the goggles, the face shields, or perhaps the stethoscope, the hand sanitizer for hand hygiene, and again, the cavi wipes. But someone has come and wanted to deliver ultrasound gel and ultrasound packs for the nurse to use with the patient in this room, and has had to put them here because the hospital was not designed with anywhere to put clean equipment if it had to be left in waiting for someone to either come out and retrieve it, or for the person who brought the equipment to don PPE and then go into the room safely to deliver it. So one of the ways that we've tried to get around this, and we've been, I think, moderately successful, is to encourage everyone to spread out the three pieces of equipment that only belong on this table. That's the pink bin here, the hand sanitizer, and the cavi wipes. But again, we've got the problem of where to put the meal tray, and again, a contaminated mask falling against the tray instead of going into the bin. Lastly, the laundry. Theoretically, the outside of the laundry hamper is designated clean, but as you can see with this overfilled hamper, the laundry cascades down the sides, which means that this bag is now contaminated with virus. And this is a problem because what we found was actually the hampers were being overfilled, partly from efficiency and partly also not to want to waste plastic bags. And we carried out the study to find out exactly how many sheets and gowns would go into one bag to get to the half-filled level. And the reason that's important is if the bag is overfilled, either the nurse or the healthcare attendant or the laundry person is going to want to compress the laundry into the bag, which will then vaporize virus into the atmosphere and contaminate individuals. And so we want to avoid that by keeping the bags only filled to the halfway point. And we were able to redesign a new pathway, which I think has worked really well. And it's been an ongoing education project just to remind individuals not to overfill, but it seems to be successful. So, you know, from a practical point of view, our triad of ethnographers and human factor specialists and infection prevention control individuals has been a really new and interesting way of looking at analyzing problems. And I think we've helped change the focus of IPC's person model. They tend to be very much more oriented towards the person, whereas I think ethnographers and human factor specialists are much more system oriented. We want to reduce the choices so that we reduce choosing the wrong thing, instead of forcing healthcare workers to have to memorize multiple choice options for different situations. And I think the IPC specialists have helped us be grounded a bit more in the realities of care. Because, for example, when we had the designated tray tables, we wanted to use tapes to show where the 3 items should go. And we're strongly reminded by IP&C that it's impossible to clean tape. And even when you remove it, it also sometimes leaves a residue, and that's difficult to clean as well. So we've all, I think, learned about the different realities of care in this time. So I've put the references right at the end for the Stelmach quote. This is one of the first publications from our group. This is the drug drawer study, and this is the Ebola study, freely available on Alberta Health Services website. And I would really like to thank my co-researchers, Professor John Conley, the infection prevention control specialist, and Miles Leslie, Rod Fadak, and Nicole Percival for the ethnography, and Joanna Black, my fellow human factor specialists. And of course, all the participants in our many studies, and the Canadian government for funding us. Thank you very much.